You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.
Welcome back to the podcast. In this episode, we're going to do a deep dive into Penthrox, so Methoxyflurane. A number of services across the world are rolling out Penthrox now, so that includes across Canada and indeed the UK. It's been in Australasia for a long time now, but is quite novel still and maybe quite unfamiliar to a certain number of providers within the UK and indeed Canada and North America. So this is an episode we recorded for the World Extreme Medicine podcast. As you may know, I'm the digital lead for World Extreme Medicine, so I coordinate all their digital activity. I recorded this with Will Duffin. He is one of the co-medical directors for World Extreme Medicine, and so it's been kindly had their permission to use this for the Pre-Hospital Care podcast. We'll be back next week with further content, and indeed we'll be releasing part 2 in the next few weeks of the conversation on addiction. Alright, please do enjoy. In this episode, we're going to examine Penthrox in the expedition environment with Will Duffin. So what I wanted to do is really examine the benefit and utility of Methoxyflurane, more commonly known as Penthrox. So Penthrox is a volatile, self-administered inhaled analgesic indicated for short-term pain relief. Penthrox is a portable, lightweight, non-invasive inhaler for self-administration of this methoxyflurane vapor. So it provides analgesia when inhaled at low concentrations, giving analgesic therapeutic doses, but can also reduce and mitigate even severe pain. And it has a short half-life. So in this episode, we wanted to really examine this drug, and I'm going to speak to Will about its use and limitations within the expedition environment, how and when it can be used, and whether it can be used as a sole adjunctive pain relief agent or as part of a larger pain relief strategy. So Dr. Will Duffin is the co-medical director of World Extreme Medicine and is an NHS GP. He's also an expedition and TV film doctor and father of 2. So he lectures around the UK for NB Medical Education and is the host of the World Extreme Medicine podcast. So just before we continue with the podcast, we'd just like to preface this with a disclaimer that these are our honest and unbiased opinions, and we haven't received any financial incentives to release this podcast. Will, welcome to the podcast.
Thanks, Owen. It's good to be back.
It's good to have you on. Will, I'd just like to start with, if we could, just why has this drug received so much attention? What's the utility of this drug?
This is a drug I've been using in my expedition in TV and film work, and I've just got so much value out of it. I think it's something a lot of our audience would find useful as well. As you said, it is a lightweight, portable, handheld form of patient-controlled analgesia in a very small package. It only weighs 60 grams. I've stuck it on my kitchen scales. That's how I know that. And I'm holding it up to the camera now. It's called the green whistle because it's this chunk of green plastic with a whistle at one end. The patient sucks on that, and the Penthrox, which is this volatile anesthetic, is in this wick in the body of the device. And when they suck air through the device, that gas vapor, that methoxyflurane vaporizes, and you draw it in. And it's just it's quick to set up. It's very versatile. You get onset of pain within about 6 to 10 inhalations, so rapid onset. Peak effect within about 15 minutes, and 1 3 ml bottle of the drug, once you put that in there, gives you about 30 minutes of continuous analgesia, or 1 hour if you use it intermittently. It's designed for a conscious adult trauma patient with a pain score of 4 out of 10 and above. And interestingly, the thing about Penthrox is although it's making waves in the UK and Europe at the moment, in the last 5 years or so, it's being rolled out in emergency departments and ambulance services around the UK. It's been around. The Australians have been using this since 1974. It was only just approved for use in Europe in 2015. So I don't know why it's taken us so long to get the memo. Interestingly, in the US, they're not even using it yet at all. They're still in stage 3 trials. They're worried about fears of kidney injury. But it's really superseding trusted nitrous oxide or gas and air in a lot of acute settings now. And so that's why there's been a lot of chat in the media and medical channels about this, and its role, particularly as a form of analgesia in the context of wilderness medicine is huge.
So, well, just you've spoken to the sort of the versatility of the drug and of the delivery chamber, but could you maybe speak to sort of the range of pathologies it could be used to treat, and maybe also how it fits into maybe a larger pain management strategy on expedition?
Yeah, Penthrox it's designed for temporary relief of pain of a conscious adult trauma patient who's hemodynamically stable. So this isn't for your major polytrauma. It's really for, say a localized limb injury. It can help you with reducing, splinting, a fracture, packaging the patient. And it's not just MSK trauma. You can use it for, say, burns, scalds, lacerations, dislocations. And there's a great case report of it being used to support a suprapubic aspiration of a bladder in someone in urinary retention at high altitude where they didn't have any Foley catheters to hand. And it was very effective there. I've actually used it for completely non-trauma related stuff. I've used it to reduce an inguinal hernia in a villager on a remote island and work to treat. And then most recently, I was using it to manage the pain of a shark bite on a patient's hand. And that was the only time it didn't work. That particular patient just didn't get on with it. It was just like, what is this stuff? It just made him feel drunk and dizzy and hated it. So it's not for everyone. But yeah, it is incredibly versatile. And for me, one of the things that I really like, other than the weight and the portability and the ease of use, is because it's patient controlled, particularly in an expedition environment where you're often by yourself or in small teams, and there's lots of other tasks to complete. You might be trying to get IV access, you're trying to organize a medevac and all that stuff. It frees you up. You can just give this to the patient, tell them how to use it, and you can then go and think about other things. And that's a massive win for me.
So you've spoken about some of your anecdotal experience with Penthrox and how it fits into that sort of larger pain management strategy. And to your point, you can maybe allocate it or attribute it to the patient for this self-administered analgesia, whilst the other you're maybe getting IV access for something else which is more long acting. But could you speak to some of the, because there is finite supplies on expedition, you've got to be really judicial about when and where you use Penthrox. Could you speak to what else you might be able to load a patient with, maybe from an oral perspective and or IV perspective, to as an adjunctive longer term use? Because like we spoke about offline, protracted field care, especially in an expedition environment, could be 4, 5, 6, 7 hours. How short acting is Penthrox?
Well, I mean, you get between 30 and 60 minutes of use per 3 ml cylinder, and there's 2 package. You can give 2 in a 24-hour period, so it's not what you'd want for prolonged field care, and that's really important point to mention. Penthrox is not a panacea. It's a good drug. It's a great thing to add in to your arsenal, but you are going to need other options as well. And I think a great starting point for that is the WMS guidelines on this, and we'll put a link of that in the show notes, which are loosely based on the WHO pain ladder. And you don't just reach straight for the Penthrox every time. You think about the kind of pain ladder, and start generally with non-drug based things, simple stuff like just the power of being a comforting presence, and comfort care, things like elevation, compression, ice, and splinting and dressing a burn, for example. And then non-opioids like oral route, things like paracetamol, ibuprofen. Then opioid drugs like codeine or oxycodone, which they use a lot in the US. And only then would you maybe go for the parenteral opioids, things like IV morphine or intranasal morphine, and then other things like ketamine. And ketamine is very commonly used in the pre-hospital world. As a GP, it's way out of my own scope of practice, but that is kind of right up at the top of the tree. I think for me, Penthrox is very much a temporizing measure, and it's where it sits within that kind of pain ladder is you want to go in at the right level. If you've got someone who's got significant trauma and is in significant pain, it buys you a bit of time. It helps you. I've got, for this, it's so portable. I can just have it in my pocket, and if I have to run to the scene, I can just deploy it very quickly. You get that running with a patient when you then do your primary survey, and they're not screaming at you. It gets them comfortable. It calms down the tempo of the situation. Then you can be more strategic about what you then deploy next. And particularly then if they've got ongoing pain needs, you might want to get IV access, or you might want to get some oral opioids on board to anticipate that. But for me, that's where it sits in that pain ladder, and we'll share the link in the show notes so everyone can have a look at that.
Could you speak to the contraindications, Will, for Penthrox?
Yeah, according to the manufacturers, there aren't actually that many. It is quite versatile, but any known hypersensitivity or family history to inhaled anesthetics is a big one. History of malignant hypothermia, any history of liver damage after previous inhaled anesthetics. So just a kind of anesthetic history is helpful if the moment allows for it. Clinically significant renal impairment is the language the manufacturers use. I don't know what you deem clinically significant. There's no set numbers there. Any cardiovascular instability or respiratory depression, there's a theoretical risk it could worsen that, which is why it's only for your conscious breathing, hemodynamically stable trauma patient. And then cautions include hepatic conditions, elderly patients with risk factors for acute kidney injury, or anything else that might predispose them to that. And there is a couple of interactions with other drugs, enzyme-inducing drugs such as rifampicin and carbamazepine, which can increase the toxicity of methoxyflurane. So there's a few things there, but I think it's unlikely many of those would apply to the kind of case mix we see in expedition environments. So I think this is generally a drug that will apply to nearly all the patients that we tend to see.
So you mentioned there about these hemodynamic changes in patients which take Penthrox. Could you maybe speak to either your experience with these hemodynamic changes, and or if there's any empirical evidence on this?
Yeah, there's some really good, because of the Australians have been using this since 1974. They've got lots of safety data and research to support the use of Penthrox. And there's a great study published in the Journal of Military and Veterans Health, put a link in the show notes. And it was a retrospective observational study of 590 ambulance patients, and they looked at how their vital signs changed before and after administration of Penthrox. And this was in otherwise clinically stable patients. So this wasn't in really sick trauma patients. And it's quite reassuring. They found that the systolic blood pressure fell from 132 as a mean pre-administration to only 130. Pulse rate fell from 85 to 79. So that's a drop, but only a small one. Respiratory rate dropped from 20.4 to 18.6. So again, it did drop, but not really by a clinically significant amount. And this study supports the conclusion that methoxyflurane is safe in hemodynamically stable patients at baseline. There's no evidence to show that none of the patients in that study suffered with any meaningful form of respiratory depression or hypotension or tachy or bradycardia. It hasn't been tested. What we don't know is what that impact would be if you did have someone that was clinically quite compromised, had kind of high amount of lactate in their system, and but that's outside the scope of use for this drug.
And just looking at whether it's possible to overdose on Penthrox, Will, could you maybe speak to either what the literature says, but what the instructions for use say about overdose?
Yeah, very much so. After all, it's a volatile anesthetic gas. The end result would be full anesthesia. You're looking at the risk of drug toxicity, respiratory depression, potentially cardiovascular collapse. And that's why it's only licensed at the relatively small doses. So 3 mils in 2 doses of 3 mils in a 24-hour period. So that's why we are quite restricted in how much we can give. But as long as it's used within the prescribed analgesic doses, I think the risks of toxicity and those other things is very low.
So looking at, someone, as you spoke to before, about who is in severe pain and really is maybe not getting on well with splintage and oral medication, and you really want to hit them with a strong dose of methoxyflurane, so of Penthrox. Could you speak to how you would maybe indeed double the dose of the drug to really get them into that sort of analgesic window?
Yeah, so you can't increase the dose of 3 mils that you can put into the body of the whistle itself, but you can. The way it's designed is quite cunning. When the patient inhales through the mouthpiece, it entrains air that goes past the activated carbon chamber, and if the patient just puts their finger over that hole, it's called the diluter hole. That forces all the air through the wick instead, and it's a way of getting a beefier dose, and that actually works really well. So the diluter hole is the key.
And just looking at finally, Will, why should all expeditions be carrying a drug such as this?
Yeah, I mean, one of the biggest problems that many expeditions, particularly in remote, politically unstable places, have found is because of the issue of importing controlled drugs and drugs of dependence, things like strong opioids, even ketamine, getting those in country and cross borders, that has been often very prohibitive. And the problem with that is then you have these trauma patients that all you've got to manage that pain is paracetamol, ibuprofen. It's hugely inadequate. And I think because this isn't a controlled drug in an expedition environment, as in addition to all of the positives I've mentioned already, it's something that can just be used quite ubiquitously in an expedition setting across the world without having to worry about that issue. I mean, it's got a good safety record. It's been tested in Australia for years. It's lightweight, it's portable, it's relatively inexpensive. And yet, for me, it's been a really great adjunct to the other pain management strategies that you need on an expedition. And it fills a real gap in that strategy that has been left by the absence of strong opioids in certain parts of the world on expeditions.
That's fantastic, Will. And to your point, even in outside of the expedition environment, the portability and versatility and the size of the device just lends itself to giving so much more ability to be able to deploy it in wilderness environments, or indeed in environments whereby there's protracted pre-hospital times in developed healthcare systems. So again, it lends itself both to the expedition environment and the pre-hospital environment, which is fantastic. But Will, I just want to say thank you for the last half an hour. What we'll do is we will put in the show notes the documents that you suggest, because I think that's fantastic further reading for people to go and to research. And thanks for your reflections as well, because I think your anecdotal reflections contextualize nicely the information and make sure it's relevant to listeners. So thank you.
Thanks, Owen. It's been a pleasure.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.